So we have four fantastic speakers for you today. Seamus Donnelly, Professor Seamus Donnelly, is shortly going to take up the prestigious Chair of Medicine at Trinity College in Dublin, and congratulations to you on that. Professor Fionnuala McAuliffe is Professor of Obstetrics and Gynecology at the National Maternity Hospital in Dublin, and you really couldn't have a busier job than that. Dermot Power has been working as a geriatrician at the Mater Hospital in Dublin since 2001, and he's one of the leading and more forward-thinking geriatricians in the country. And Shane McKee, Dr. Shane McKee, is a consultant and clinical lead for genetic medicine based at Belfast City Hospital. So, a fantastic panel. Thank you all for joining us. And what I want, because it's a bit of a mystery to me, and I'm sure everybody here knows more about it, but if you talk to me about what connected health is to you and what your experience of it has been, and maybe Seamus, you'd kick off.
Yes, thanks very much, Anya. I suppose I got interested in connected health a few years back when a patient said to me, Dr. Donnelly, she said, we'll all be patients one day. And that registered with me, and that's a very powerful statement, that healthy people at some stage will not be healthy. And when I'm not healthy, how would I want to be looked after? And I would like to stay at home as much as possible. The comfort of my home, my friends, the environment I know that at some stage in my life when I'm not healthy, I'll have to go to hospital. I don't want to be in hospital. I want to be at home reasonably quickly, but in a safe environment. And I think that connected health in relation to the quality of engineers, the quality of computer scientists in Ireland, the sensors that they're developing gives an opportunity to Ireland, give an opportunity to clinicians linking in with these scientists at early stage development to validate these sensors as a sort of an early warning radar system of how well you are or not well you are in your home. And in a practical way, I would see in 3 to 5 years, certainly in the States, maybe a little bit longer in Ireland, that such systems would be unobtrusively assessing you in your home environment for wellness and empowering you, feeding back to you how well you are and you working to make yourself and keep yourself well.
What's the biggest challenge there? Is it cost, trust?
I think there are many different things. I think trust, and we look at the GM and the food, genetic foods, and the fear factor that was created somewhat irrationally and somewhat rationally. And Big Brother watching you with the connected health would be a natural fear of people. I think what will happen in the future is that people will want to be part of it and will consent to be part of it, and they'll be actively looking after their own health with the help of technology, mobile phone, iPad, whatever it might be in 5 to 10 years. And they will get feedback of what they're doing, how good, bad, or indifferent they are. And we're competitive beasts. I had the Fitbit for a little while, and 2,500, 3,000. I'm going to get 5,000 tomorrow. There'll be that element of feeding into our competitive nature for wellness and keeping us healthy. So that's sort of a background of where I came from and how it interests me, and how I think it will, certainly when I'm older, will help me stay at home and be healthy.
Realistically, because you said you can see these changes happening in the States fairly soon, but realistically in Ireland, what do you think we need to start doing now, given where we're at, practically?
Well, the Irish Health Services would not be noted for its rapidity or initiative in early phase responses.
You should have had a career in the diplomatic service.
So, the kindest thing to say about the HSE, it's a super tanker. It takes a long time for turning, but there's a lot of good things that go on. It's just novelty and innovation is not its strong point. So that's why I think private medicine in the States will adopt this technology sooner, be validated in external patient populations, and then will be imported to Ireland, I would suggest. Bailey's Irish Cream, it was successful abroad, and then we started drinking it back in Ireland. It'll be an element of that. I think reimbursement is the reimbursement model is a significant impedance to it being absorbed or taken up in America at the moment. There isn't a natural model. Healthcare payers, providers, politicians are not good on paying for wellness. They're good in paying for a specific item. a fee per item. You've got a broken leg, we pay for it. You've got jaundice and liver problems, we pay for it. But keeping you well is something that isn't quite in the payment schedule at the moment. So that's a significant barrier at the moment.
Okay. And Fionnuala, talk to me about, because we can understand how, for instance, this kind of technology could be really useful in the short to medium term even, were it available, for people with ongoing conditions. But in terms of maternity applications, what does Connected Health mean to you? What's your experience of it, and where do you want us to start going?
Well, I mean, pregnancy is a unique time in a woman's life where she's open to suggestion of healthy lifestyle, and you have an opportunity to improve the health both for the mother and the baby. I've been very impressed how information-seeking pregnant women are. They often have apps on. They're always asking, where can I go for information? So really that got me interested in how can we deliver high-quality information to pregnant women to advise them how best to eat in pregnancy, how to exercise. And when we give them advice, of course, how do we make sure that they adhere to that advice? So I think there's great opportunity there. I mean, pregnant women in general are healthy, so the idea is to, if they adopt a healthy lifestyle, to remain healthy, to avoid gestational diabetes, excessive weight gain. I mean, there have been some progresses in the connected health area. For example, the HSE has developed a WhatsApp Mom app. So pregnancy is perhaps one of those areas where the HSE has shown a little bit of leadership in producing high quality information. But I think we can go further in terms of blood pressure monitoring, so that would avoid a pregnant woman coming in for monitoring for blood pressure. She could have that done at home, entering her blood sugar levels, for example, if she's diabetic or if she's at risk of same, entering weight and so on. And then when she comes for antenatal visit then, rather than trying to gather all this information, that this information will be available, and particularly a lot of the interventions in pregnancy wouldn't be drug-based because of the safety issues. They would be nutrition-based, exercise-based. So by recording the woman's diet and her exercise and getting feedback, if she's getting feedback on it, she'll be motivated to adhere to the advice, and also then the clinician can see, well, you've done really well, have you considered looking at this?
And where do you foresee that going? Because it sounds, as you say, as if it's fairly advanced. What more could happen in the whole area of connected health and pregnancy? And is there a role, particularly after birth?
Well, I think, there's a few areas. There's preparing for pregnancy, there's pregnancy, and then afterwards with breastfeeding and parental support. So there's a lot of opportunity there.
Particularly now that hospital stays are shorter, so much shorter than they used to be. So in terms of, getting somebody to help you start feeding or whatever for an inexperienced mum.
And there are sort of apps out there, but the question with a lot of the apps and the information out there, is it any good quality? So I think it's important to do research around these technology platforms to actually show, oh yeah, this one is effective, this one is instigating change. I think the main challenges that I see is safety of data protection. So is the data secure that the patient is entering and then delivering to the health service? And then of course the safety around, if a mother records a high blood pressure, is there going to be a red flag somewhere, or is she going to continue to record high blood pressures and then come to some harm as a result? So there needs to be a safety there.
The data is only as useful as the attention that's being paid to it in real time.
Yeah, so I think that really needs to be dealt with. You wouldn't want a woman having high blood pressures, high sugars, and not seeking medical advice, thinking that somebody else is actually monitoring those. So those are the two areas that I would see would need to be developed before we could roll it out.
All right. Dermot, the first time I met you at a similar event like this, it was the screening of a really interesting movie, and it started off by looking at premature babies that depended so much on incubators, and it was looking at the role of technology in all of our lives. And you were talking at that day about the fact that all of us now, or certainly if not us here in this room, most of our children will be able to look forward to phenomenally long life expectancies. And then, of course, there's the capacity issue at the end of life. And, the fact of the matter is there just aren't enough people, and there just isn't enough money to be able to meet people's desire to live an independent and fulfill life for as long as possible. So, but at the same time, there's this gorgeous dream, like the movies, and then I suspect there might be the real century that we're living in. So will you talk to us about, if you like, the dream and the reality?
There's nothing wrong with your memory, is there? I don't think you'll be coming to see me for a while yet. No, I kind of got interested in this area because both in trying to help older people stay out of hospital and to facilitate those who come in going home that much sooner, you know. And there's a tendency when we talk about older people to kind of think older people and technology don't go together, you know. But I think people forget that people who are older now, 60s, 70s, 80s and beyond, are the generation who saw the electrification of Ireland, who saw the first TVs and RTE starting, saw the first colour TVs, you know, got involved in the internet, ATMs, all those kind of things that even at my stage, you know, my kids say, you know, well, did you have ATMs when you were a kid, you know, making you know, the kind of questions you get asked. My father was a soldier, and he said, did he wear armour when he was in the, you know, thought he was a knight or something. But my point is that, you know, older people and technology shouldn't be separated. We should be engaging and embracing them. And in terms of keeping people out of hospital, there's an opportunity in what Seamus was talking about to monitor people and direct them in the right way to the right physician to help them. There's a tendency for us, particularly when it comes to older folk, to have only one door into the health services, and that's through the emergency department. And the consequence of that is visible every day on trolley reports and on your news programme, which it gives great coverage to these things, that there are too many people on trolleys. And the other consequence of it is that, you know, with the best will in the world, when somebody makes it into hospital, there's a tendency for them to get medicalised when they're in there and to find it hard to get out because, you know, there's a whole lot of things kind of conspire against them. And technology can help at the entrance point in terms of directing people the right way, maybe catching things a little bit earlier, and in terms of getting people out that much sooner, supporting an earlier discharge. One of the things that kind of prompted me to look at this was when we had kids in the creche, you'd come home you'd go and pick them up every day, and you'd get this little report on how they did, and it'd be terribly twee and cute, and they ate this and they played with that. We pay, as a state, loads of money to care agencies to go in and look after people in their own homes. Yet there's no, you could argue that we're paying, albeit at a low level, health professionals to go into somebody's home, but we don't ask them to do anything except, you know, mobilise the patient. They should be checking the blood pressure. They should be weighing the patient. They should be involved in those kind of things which can be done electronically and fed back through whatever system to somebody who can monitor. You're already paying for them to be there. Why not take advantage of that? And that was one of the projects that we tried to get involved in, getting people out early from hospital on a home care package that they were already being funded to receive, but empowering the home care agency to do a little bit more. And with a small pilot project, we showed quite an impact. Now again, you know, I think we've probably all been involved in pilot projects that have done well. It's mainstreaming it then that becomes the challenge, and who pays, because nothing is going to be for nothing. And one of the problems is that the way we've designed the health service is that it's nobody's responsibility to do this, you know. At the risk of being slightly controversial now, but to the community, if a patient is in hospital, they're not paying for them, so that's cool, their budget is being met. To the hospital, they want them out and back into the community, and they're looking foolish for having people on trolleys in A&E. So there's, you know, where's the pressure points, and how do we get people to pay and realise that ultimately paying for this kind of thing saves money overall, and it's conveying that kind of impression that's going to me be the real challenge. And
is there a way, because my dad has been at home on, in fact they sent him home on a pilot scheme and he's lived for 12 years. And I don't think anyone thought he'd survive that long. But anyway, he has, fair play to him. But one of the difficulties we've experienced over the years, and is there a role for technology here, is precisely that. If you're in the community, you're in the community. If you're in hospital, you're in hospital.
And never the twain.
But exactly, your only way back in a crisis is to go through emergency. That you get stranded in the community. And the problem is, of course, when people have ongoing conditions from time to time, there are crises. What you want is an easy way to get in and out of hospital very quickly, and that seems to be the big choke point we have with older people who are sick at the moment.
It's creating other doors into care, into expert care, and you know, I think technology can help with that by identifying more directly what the problem is at an earlier stage and directing it to rapid access clinics or, you know, early access outpatient, whatever model, whatever name or whatever natty title the thing has, but avoiding the A&E department. Inevitably, people will need admission, but if it can be done more electively rather than more emergently, you'll end up with a better outcome for the patient, and they won't be terrified. People put off going to the emergency department so long that by the time they arrive, the situation is just broken down completely, and it's frightening for people being in.
And you
those
do get
environments.
the experience with older people, or anyone indeed who's been through A&E a few times. They will, hide a lot of symptoms often in order to avoid going through that again.
Yeah,
They just think it's, because it's a very distressing experience. Do you know what I mean?
Yeah,
Even if they,
should try working there. Yeah.
Yeah, I would. And fair play to everyone who does, because anyone who's working in that area, I think, families develop a huge appreciation. What I want to talk to you about, Shane, is in a way, it's, we can all talk about the application of kind of new technologies and connected health, and it could all be joined up. But there is the brave new world, particularly when we start looking at the area of genetics. I know that, in many parts of the States, employers monitor electronically and with various kind of other ways their employees' health, and it's great if you're healthy, but if they detect that your blood sugar's gone up, if you don't take measures to correct it the following year, you can be in trouble at work. So there's all this kind of sneaky ways. Then we know about the Reagan virus today, so why should we trust anything on a computer, and yada yada. So there are huge risks as well as upsides to all of this, aren't there? And I suppose in the field of genetics, that's particularly keenly felt.
Yeah, I mean, the thing about the genetic side is that with recent developments in genetic sequencing technology and new things that have come through, and also with bioinformatics, the science of dealing with the vast amounts of data that are coming through from genetic testing, whether it be of genetic testing of people's tumours or their blood system to see if they've got any genetic disorders, because that has progressed very, very rapidly, immeasurably over the past 15 years. That has given us a vast new range of data that is now starting to creep further forward in the patient journey. So currently what you would do if you're doing some of these what used to be thought of as quite expensive genetic tests, we would have done those after you've pretty much exhausted nearly everything else. So you've done all your normal blood tests for patients who are pitching up at your clinic. You want to know what's wrong with them, so you'll test for one thing and another. And eventually, after maybe several visits and after having spent maybe several €1,000 on their diagnostic tests, then you'll maybe run a gene test for something which is going to cost maybe another €500 to €600. And then you'll find a result. That's now changing. That paradigm is shifting around completely to where the genetic information, the patient's genome, is going to become part of the standard start-off information back at the start of the patient's journey. Some people have even talked about it at the time of birth, or even prenatally, getting their genome and then having that banked in a computer system and then ready for analysis to look for risk factors for various diseases. Now that's all well and good. I mean, we're talking really, I should have maybe mentioned again what that kind of thing is likely to cost. Back in 2000, when the first human genome was sequenced, it cost about $2.5 billion to sequence a human genome. And every 2 years since then, we've knocked a zero off the end of that figure. So it's now about, it's under $2,000 to sequence a genome. That's a tractable cost. That's starting to be something that is looking much more likely to be a test that you can map back to the start. So the challenge is going to be to integrate that information, that very complex and still poorly understood and poorly charted genetic information, into the patient's overall, both their record and then their care plans as they move forward. And that's one of the big challenges, I think, for connected health, is to incorporate and to pull together those different strands. So your normal biomedical tests, your patient history and symptoms, your genomic information, and then critically, and this is something that I did want to get a bit of a mention in this session, but critically the patient's viewpoint. In the ePatient Dave talk, which I was just blown away by, I thought it was the most amazing talk, because in so many ways that is where we're going, and to adopt that sort of approach, even with complicated genetic information and complicated biochemical information. These are things we can do already, and one of the biggest things that we can do is just to take that monitor screen and swivel it through another 45 degrees and bring the patient into the discussion. So a thing that we've done in the North over the past couple of years now is to develop this, well, with the help of a company in New Zealand called Orion, to develop a system called the Electronic Care Record. Now, a lot of you will be aware of that, and you'll know why we've been able to do that, because we've got an integrated health and social care system in the north. We've got a unique patient identifier that can track all the patient information across multiple hospitals. So this is, we're quite lucky to have that infrastructure already there. But we've been able to pull all this information together into a single portal, so that in a 15-minute consultation, or half an hour, or 45 minutes, I'm quite lucky in my medical practice. I get 45 minutes with my patients. Some of my patients, maybe that seems a bit long, but it's great. But it means that you can actually then start to get that information available to the patient. Who's your neurologist? I might ask, or I might have used to have asked to the patient, and they'll say, oh, I don't know, he was a wee man, he's got a beard. And then that is, okay, I know who that is. But now I can see all their appointments and things up, and they know their appointments as well, and I can say, right, next week you're to go and see him. Do you know about that? He says, oh, thanks for reminding me, I'd forgotten completely about that. So we're starting to try and find a way of pulling this all together. The Brave New World, the genetic side of it, yes, that's one big aspect of it. And being able to, as probably a pretty clinically inastute doctor, being able to just get that genetic information in and not have to actually ask questions before I have that data through, that makes me feel much more secure. But it's pulling that together, and I mean, to me, that's what connected health means. We've got all this information from multiple different sources: genomes, biochemistry, physiological data, Fitbits, even where you are, and it's getting that into a single portal where
but
it makes sense.
But you mentioned it's not just a single portal, it's also kind of, once you turn that screen, the 45 degrees, it's also the understanding and the engagement of the person who's looking at that information. Now, I love medical information. It wrecks my head. The doctors know things about me that I don't, that things pop up on their screens that I don't know what's in my... Do you know, I really find that almost an infringement of human rights. But equally, in fact, probably I would say the majority of patients, they want to trust you guys. There's a lot that we don't want to know. And also, okay, it's one thing if you have the BRCA gene, which gives you a 70-80% risk of developing certain kinds of cancer. It's another thing to be told you've got a combination of genes that together might give you a 20% risk. Now, over a lifetime, what is that? How do we manage that, Seamus? How do we manage the communication with and the engagement of the patients? Because, to be quite honest, most people walking in a hospital door, no matter how clever we are in normal life, coming in that door, we're scared, we're nervous, and we're not thinking clearly.
Well, I think anybody, medically background people going in as a patient, are scared. I mean, everybody's scared, and their ability to reason and rationalise, they need guidance from an independent practitioner. That's a very tough. I think one of the things about connected health will be empowering the patient with regard to the information. Some people will want full disclosure. Yeah. Some people will want it edited down, and the doctor, and that connected health will allow that. But also, I think it's, rather than disease and being unhealthy, I think the emphasis is in patient empowerment on being healthy for as long as possible. And I think feedback about positivity and health will be very important. We've done, Brian Caulfield and I, a lot in Insight, done a lot of work in relation to trialling over 25,000 days of recordings we've done the last few years. And the most important thing that's come back to me and Brian is feedback to the patient. Even if it's inaccurate, positive feedback to the patient. We mentioned this Fitbit before. We've done Fitbit where we've tested how accurate it is with regard to how far you've travelled in advanced chronic bronchitis, so shuffling gait, and it's useless. It says 5,000 steps, it could have been 3,000, it could have been 8,000. It's not accurate. But we've done trials with patients where it's fed back to them. Yeah. And when we actually measure what they can do after 6 weeks, it's 15 to 18% more on inaccurate feedback, but it's appealing to the person. And that's, I think, bringing the person, engaging the patient, engaging their family with positive information and positive reinforcement, rather than the negativity of a 20% chance or a 10% chance of a disease in lifetime. But dealing with the now in a positive way will be the way forward, and will allow more maximum take-up of the technology.
And I think in a way it's interesting in the area of pregnancy, women see themselves as participants in the pregnancy with the doctor. So women approach pregnancy as something that they're active in. An awful lot of the rest of our health management we're pretty passive about, and we wait, don't we, until, a doctor comes along to make us better. So in a way, it's a novel concept, it's a novel approach, and it's one that's certainly far from traditional, but there's a lot maybe we can learn from, you know, people are able to do it, they do it in pregnancy.
Well, I mean, pregnancy is a unique situation in that, you know, the mother isn't really a patient. She's just a woman who's pregnant. So there isn't that illness relationship. And they're a very information-seeking group of people. So they're already on the internet looking for information. And it's very much a collaboration, the management of the pregnancy, and they're very open to the advice that you give. So pregnancy is like a teachable moment where people are open to the advice. If you give them healthy lifestyle and exercise information, they're much more likely to adhere to it. And then even we've done some studies to show that they'll adhere to it on afterwards the pregnancy, and perhaps introduce their children to a healthier diet as well. So it's a nice time to deliver information, and they really are very information seeking, very open to any of this information.
Which is fantastic if you're a good person and you want to be a good patient, but I could see a lot of people going, I'm not putting that on, that doctor will only know that I had a drink last night. Or, do you know what I mean? So there are, but there, you know, beyond that, there are more important issues of privacy. I suppose in the area of particularly older people, Dermot, how does a doctor go about reassuring people there?
Yeah, it's a tricky one. You know, it's hard to get the balance right. Do you remember a couple of, was it 2 years ago, that poor unfortunate lady with Alzheimer's disease went wandering and she ended up being found just up in Ballymun there with her dog. I mean, it was a tragic and quite a poignant story. There was a lot of discussion in medical and geriatric circles at the time around, you can use location tags, iPhones, whatever, to find where people are. There's a civil liberties argument on the counter side to say that it's an infringement, that somebody with a severe dementia, who's the very person who needs it, can't consent to it, therefore you shouldn't do it. I mean, I'm probably a little bit patrician in my approach in this one, in that I think it's the right thing to do and therefore should be done. And even in this woman's case, a tag on the dog would have found her where she was, you know. So it is hard to get that balance right between invading someone's privacy. You know, yet at the same time, we've got a younger generation who put everything out there on Facebook and have no privacy or concept of privacy whatsoever. So I think the whole definition of what privacy is changing, and perhaps we need to revisit it, not with a sort of a lens of academia, but look at it in terms of what is practically happening. People are living their lives. You know, update. I'm at the IPOSI conference. I'm not involved in that kind of stuff, I have to be honest with you, but there are different approaches now than perhaps there used to be. And I think as we move forward, the current generation, who are perhaps more Facebook aware and all that kind of stuff, will perhaps be quite liberal with people knowing this kind of stuff and perhaps even sharing that kind of information. They certainly share more than they should as it stands.
Don't talk to me, I know. I know that one of the things when we were filming the cancer documentary, one of the things that really struck me when we went to MD Anderson in the States was one of the guys we were talking to, his medical file was on his mobile phone. He had everything there, all his latest results, everything was updated, so if his appointments were changed, things needed to be rescheduled. And it was there, and which compared, you think of all the phone calls that would save you think of all the poor secretaries carrying around huge files that, now I'm not saying they wouldn't be busy in other ways because all this data would have to be managed, but it does look like the future, doesn't it?
We mentioned there the sort of the community and the acute hospitals working almost in two silos. But even at the level of the acute hospitals, you've got, different acute hospitals holding a record. I would have a patient on the north side of Dublin who has a medical record in the Mater Hospital in St Mary's in Phoenix Park, maybe in Clontarf Orthopaedic where they've been for some rehab, and perhaps then a record with their GP, and none of these records know the other record exists.
You have to start from scratch each time.
Yeah.
Which is just come in there to say that there are developments in the maternity area to improve this. So we're developing a national electronic maternity record that would be the same across every maternity unit. The same minimum data set would be gathered and in the same way, so that it would be easily transferable. At the moment, we've got a common maternity chart, so that if a patient comes to me from Mayo, the chart is exactly the same as the one that I have. So I think the maternity area, it could be a nice area to start some of these. It is a sort of a unique time. It's it's not sort of uncontrollable in terms of data management, and that could be a platform from which the hospitals could move for a national electronic patient record.
It sounds like, I mean, how realistic do you think that might be?
Well, certainly there is work ongoing, and so there is going to be a national maternity record at the moment coming in the next couple of years. Within Dublin, all of the records have been electronic for the last maybe 10 years, and the same data is collected in the 3 maternity hospitals. So, I mean, that is coming in the next, very soon, in the next maybe 1, 2, 3 years for maternity services. So that probably will be an example of a national electronic record that could be rolled out then into the medicine, surgery, acute services.
Okay. Do we have any, because I'd hug these guys all evening, but is there anyone who wants to put any questions or join in at this stage? Yes, there's a hand, somebody has their hand up there, and we have and we have another person here.
Thank you very much. Owen O'Brien's my name, and I'd like to say how much I agree with all the sentiments expressed by the panel. I'd like to just take up one point that Professor Donnelly made, and that is about how reticent we are in the health service to adopt new technologies. I'm depressed every week to receive by fax reports from around the country of patients who are coming to see me. And I think this is an example of just how behind the times we are in the health service, that we still adhere to the fax machine, which in my opinion should be relegated to the dustbin. But that's only one example of how slow we are to adopt new technologies. I'd like to just put to the panel one other thought, and that is that we've considered everything from genetics to old age. We haven't gone into that area which we as doctors are very bad at dealing with, and that is death, and what patients most want when they come to the point of dying, that inevitability that faces us all. And it seems to me that this is something that IPOSI might well consider for a future debate. Most patients would love to die at home, of course, in the ambience of and the company of their loved ones. But most patients, in fact, die in hospitals, which are the most unsuitable places for death to occur. I think any of us who have worked in the hospital service will recognize this fact. Hospice movement accounts for a number of deaths, but a relatively small proportion. So I think this is something that we need to face up to and look at perhaps in a future discussion.
Okay, thank you very much for making that point, which is very topical at the moment. I know there's a lot of discussion of it. Yourself as well, and then we'll go back to the panel.
Thank you. Matic Smiglic. I'll just make maybe if I may, a comment to the Facebook and the, publicizing all the information that we have. What I've observed recently with the undergraduate psychologists is that there's been a shift. They seem to have grown much more aware of the privacy around Facebook, around social media. So I think that there's this phase is slowly waning out, so that the younger kids are much more aware, and not just posting stuff all over the place like we or the generation, which is now 20 to 30 years old, was doing.
Yeah, and there's also less trust, isn't there, of the big Googles and all those big companies now. So you could see how all of that could develop. And so that point about. Again, I suppose you're always going to be, you doctors can see the benefits of these things. I can easily see all kinds of headlines you could run in weekend news. You could have 10 years of this. I mean, what it would do, though, is create fear and suspicion. And that's the last thing you want, because the danger is that, in an area of health, I doubt it would happen in maternity, but somewhere along the line, that, you would end up with something that, would end up as kind of an Irish water development, and that would hold up back, if you like, the expansion of this in the health service. So that, and also the point about death, and can all of this connected health model help improve the management? And you're right, most people die in ways they don't want to, in places they don't need to be, and it's just heartbreaking and avoidable if we put our minds to it. So maybe a final thought on all of that.
Well, I suppose of the four of us, I'm Dr. Death, really. I deal a lot in that.
Yeah, we don't want to see you.
that side of the market, you know. I mean, Professor O'Brien is a genius and a techie to boot as well, and knows much more about this kind of stuff than I do. But you know, I find that the people discuss in a notional way concepts around death and how they'd like to pass away. It's rare enough that people have sufficient insight at a stage when they're capable enough to make those decisions or engage in those discussions to be adequately informed about how they're going to feel at a particular point further down the road in time. You know, when it comes to the time, people may feel entirely differently and shouldn't, and it would be unfair to say, well, actually, you know, you made a decision a few years ago, you didn't want the antibiotics, so, you know, you're not getting them now. So you need to kind of be flexible in your approach, and I think it's about education of patients and education of staff and physicians around decision making and what's appropriate. And again, for us in the hospitals, it's also about just because you can do something, doesn't mean you should do it. You know, there are.
It's about talking about when to stop, isn't it?
Yeah, and it's not an easy conversation either,
No.
Either for the patient or for the doctor,
Or even the family, while the patient and the doctor may be able to, the family may not. So Fionnuala, you're dealing with birth, which is the other end of the spectrum. But can you see, maternity services are to the forefront in this area in Ireland at the moment. So in the development of all of that, do you see that maybe in future you'll have more patients kind of coming in, going, what do you, questioning you about your electronic record, or do you see that it's going to have, you're dealing with a clientele that wants to embrace it?
Well, I think data security is paramount, and I mean that really needs to be sorted out so that the patient gives her consent for the data and she can be fully reassured that it's completely secure, and just because it's in electronic version it's not going to be passed around. I mean, as I've said, the 3 Dublin maternity hospitals have been, we have electronic patient record, we're still using a paper one, but it's all electronically collected for the last sort of 10 years. And anyone who wants access to that data, there's a certain process to be gone through. But once we start giving patients devices and they're entering data at home onto a platform where a midwife is looking at the data or an obstetrician, well, then you're into more concern about safety and who's going to look at that data, and just say they go home early after lunch and miss the fact that those blood pressure readings are abnormal. What's going to happen there? So I think there's data security, and then there's safety of the information when it is received. Is it acted upon? So I think those things need to be teased out. But certainly as a group, pregnant women, they tend to be very open for technology and very keen to engage with it. So we're not dealing with those issues
anything
that
makes
foreign.
their baby better. Seamus, it strikes me listening to this, there's obviously a huge technological, curve going on, a huge medical curve going on. Maybe in a way what we need to do as well is start having some of these discussions in schools, maybe as part of CSPE, that, the generation that is growing up now would start having conversations about technology and their health and data and knowledge about things that were secret up to now and private.
And I suppose this is one of the objectives of today's meeting. It's an initial small step in IPOSI and Insight, reaching out to society to explain connected health and the potential benefits. I mean, I do think there are challenges ahead. I do think we have to be extremely careful. Irish water, GM foods, whatever it might be, the scare factor of Big Brother is not to be underestimated. I think data security, as Fionnuala mentioned, is absolutely paramount. And one way of getting over that might be that you own your own data. It's not owned by the state. You have it on your own, whatever the iPhone of the future is. And when it's given to the state, it's anonymized. So when the doctor's looking at it in his clinic, or when they're doing cancer statistics for Ireland, it's a number, it's anonymous. But you actually own your own data, and it's yours in possession legally. That might be the way of protecting. Like the NHS in the last 2 or 3 months has done these contracts, national contracts, selling the data to actuarials, to commercial third-party entry. That's not appropriate. And it's not I don't think it's, certainly as a patient in the NHS, I would not want that. So I think one way of working at it would be using technology to transfer the ownership exclusively to you of your own clinical data.
Yeah, like all very good ideas. It sounds so brilliantly simple and
But they're, you know,
could
they're,
work.
conceptually,
Yeah.
you mentioned the MD Anderson
Yeah.
Cancer Centre. They conceptually they have it in their person. Now they legally should own it. Wrap it around it. It's just, I think that'd be the way forward.
And Shane, I mean, you were talking about the integrated system you've got in Northern Ireland, which I imagine we'd probably have to have a constitutional referendum to be able to replicate. But looking from the perspective of being so much further on, I suppose, in that infrastructure, to continue the Irish water analogy, than we are, what advice, what lesson, what parting thought would you leave us with?
Well, I think Seamus's point is probably one of the key things there, and I don't know whether I'm being a bit obtuse or anything, but I think where we got it right in Northern Ireland, where the NHS in England got it very badly wrong with the care.data scenario, was that the concept, at least, if not in practice, at least in principle, the concept is that it's the patient's data, and it's not up to us to then sell that on. So actually in Northern Ireland, legally, pardon me, at the moment, we don't have a legal basis for secondary use of data. Now that actually is a problem, because if you're then trying to mine this data resource to try and identify patients who are maybe being underserved or who have particular needs and bring them together, or even just to get government to sort of develop new policy that says we've got X number of patients who have Parkinson's disease, diabetes, multiple sclerosis or whatever. At the moment, we don't have that, but there's legislation going through that we're trying to get that moved along with. But I think the key thing to everything to do with data always has to be to have the patient's centre in the whole thing. It's got to be who has the ownership over it, and if people feel that their ownership of their data is being compromised by it being sold, for example, to pharmaceutical companies or to insurance companies or whatever, to their potential detriment, because they feel, I think certainly at least in the NHS in England, a lot of people have felt that they're like marketing targets rather than recipients of care, and that's maybe a little bit pejorative, but I know plenty of people who feel that way, and it's the perception that is often the reality, or at least it becomes the reality. So I think that's really the key challenge, and what we've tried to do is to make sure that the patient stays centre and foremost. So things like patient portals that have been talked about, like engaging the patient in using their information. I think those are very powerful paradigms. They're not complicated, very simple, but realising them is difficult. But it starts, as I was saying before, with just tilting the screen and bringing in the patient.
Okay, listen, thank you and thank all of the panel. You're allowed to clap now. Thank you very much indeed for this contribution today.